So we do. So did you want to discuss anything else of that, or should I
That's
just
all
get
good.
Okay, yeah. Awesome. So I will just read some of the questions from the queue again. They get voted up and down, so I'm just going to do my best. I started a couple of them as they were coming in. So from Heidi Sue Roth, having reviewed the research on diet and anti-inflammation foods, there is a lot of disagreement on what to eat or not eat. Were there specific studies that led to referencing the Mediterranean diet?
Yeah, I think as soon as we look at diet stuff, it is very complex. And I think with some of the studies that you look at where it's also only manipulating sort of one thing, like what is the effect of adding this to the diet? Is this a superfood? It seems that, I mean, probably for many people, as long as it's a move away from processed foods, I think probably that in and of itself is a very good first step, regardless of the exact diet that it's being replaced with. So I would say we can continue to probably look at the literature within this, but the biggest thing would be trying to go towards natural and normal, not processed. Yeah.
Awesome. I like more options instead of fewer. So just less processed, easy enough, or at least a good start. Okay, so just a comment from Louise Truern. Fantastic presentation, Tasha. Thanks. Your explanations have altered the way I think about my OA, and I now use the term wear and repair whenever I talk to others. Making
Thanks,
a difference.
Louise.
All right, from Melanie Connell. Research has shown the prevalence of OA within 15 years after ACL repair. Is this similar low-level inflammation paradigm, or is this a similar low-level inflammation paradigm?
Yeah, it's a really good question. So we know that oftentimes when there is a significant injury to the knee, for example, like ACL tear, is that it can be more common to develop osteoarthritis. So it can show that there currently or certainly are contributing factors that are peripheral related from the joint. But it's the idea is that, I mean, lots of people undergo have an ACL, but not everyone gets osteoarthritis or an osteoarthritic pain. So one of the, I think, hypotheses that we are considering is this idea that it's almost a cumulative thing that's occurring that then results in suddenly there being symptoms. So potentially it's, starting to not eat very well in a highly stressful situation. As you do get older and inflammation becomes a little bit higher, and then you do get almost like a culmination of things coming together where we almost picture it as tipping over and suddenly we're into a pain situation. So I think I'm not aware of evidence that suggests that we shouldn't think that inflammation would have a contribution in an ACL type OA.
Okay, thank you. Okay, next one from Ian Levitt. I'm always surprised and saddened when a patient comes to me with this horrible narrative about their x-ray results and what their doctor told them. Is there any suggestion on how to bring this up with MDs, medical providers, to change their language?
Yeah, what a good question. I guess one of the things that we've been trying to do in Australia is to reach out to radiologists and have them give a lay summary of their report. So obviously they have to report everything, that's their job, and point out everything, but whether or not they can create a paragraph for patients that puts the findings in context with what we would expect for a person without pain but a similar age. And we can get a couple people convinced, but to me that is probably a start. In terms of engaging, medical doctors, we had this talk actually online on the Zoom. I joined and just chatted with some of the people that were online, and that is a really, really big barrier. Like it's a hard population to reach. We try to reach out to GPs a fair bit, and I think probably the best way about it is to try to get into medical schools and start to get into those teaching programs. And I know that there is certainly a push within Australia within standardizing some of the education that they receive about pain, but it is a hard slog. Because ultimately, and this is another thing that was brought up, you get this clinical hierarchy where, of course, if the doctor says it, do they listen to the physio? Sometimes, but it's harder.
Definitely. And then I love this question as our last one from Anik Tracy. Do you know why did we originally think that OA equals pain or wear and tear? Do you think ortho physicians respect this literature and will change their narrative to the people they see?
Yeah, it's a good question. So, I mean, a lot of the research into osteoarthritis used animal models and looked into trying to understand this and used injuries of joint damage within an animal model to look at progression and to look at drugs and to things like that. But a lot of it, I think, did come from the idea that often when you have a knee injury, you tend to be more likely to have OA down the track. So it was sort of, yes, a contributor, but assumed to be a very important and or sole contributor is whatever is happening in the joint. What was the second part of that question? Sorry. Oh, it's on the screen. Do you think orthophysicians? So interestingly, we've had more luck with orthopedic physicians and surgeons than we have had with general practitioners in taking up the message. And I think part of that is probably truthfully a bit financial, because they've started to have clinics within their practices that are a bit larger, so that they are working with rehabilitation professionals such as physio, such as things like that. So I think it's much more, they're much more aware of it. As an example, like we're starting to get invited to speak at their conferences, which is pretty awesome. I feel like you're like going into the tiger's den. But it's good, because you do get people then that they potentially they've had their expectations challenged with a patient. So they've had someone that they would have thought absolutely was going to have surgery, and have managed to be convinced to try an exercise program, and they see that. So I think it probably is similar to other behavioral change literature, in that we'd have to have them experience it themselves to really get them on board. So we try.
I love that. Get them to experience that things can change, and then the physicians might change. Okay, well, thank you, Tasha.
Beautiful.
We're so happy that you made it here in person.
Thank you.